We would like to welcome you. Thank you all for joining us this evening. My name is Shayna Overfelt. I'm your moderator, and we'll be guiding your questions this evening. We really hope that you will interact with us tonight via some features that the Zoom offers. We've all become very accustomed to this in this day and age. So let's quickly just review some of the things that you're going to see as you come into this meeting. First and foremost, this meeting will be recorded and it will be shared post recording this evening, hopefully tomorrow, so you can refer back to it should you need it for any state board meetings coming up. To begin with, you are coming in as a muted participant. As a muted participant, you will notice that your slides that your microphone has a red line through it. We are accepting commentary and comments and questions through the chat. So with the chat, if you can enter any questions you may have, we have some pre-submitted questions we'll get to as well. And make sure when you're selecting your chat that you have the choice of choosing to send it to just the panelists, or you may send it to all panelists or any host directly. I'll wait and give our slides just a minute to catch up. Dr. Weingarten, it's not just me. Are you seeing the slides yet, or are you just still seeing our main home screen?
Home screen.
Okay. Make sure I wasn't missing something.
I'm sure that there you go.
There we go. So we already covered this. This is our mute, how to mute. You're muted as soon as you come in. For this webinar, the mute function will stay active. If for some reason you find yourself not muted, please go ahead and mute yourself as promptly as possible. We did also cover the chat. Please, again, chat with us. This is an interactive meeting. We're here for you. The purpose is to answer your questions and also give you information on the exciting things that the CDCA has been up to. And then last but not least, you can see a list of participants. We are so excited to have, I think last registration numbers were almost 180 participants in this meeting tonight. So that is exciting for us. We thank you for spending your evening with us. And as you move towards the West Coast, it may be afternoon, but we greatly appreciate you being here. So real quickly, I'd like to introduce you to our hosts for this evening. First is our chairman, Dr. Harvey Weingarten. He is a graduate of Indiana University. He currently serves as the Associate Dean for Clinical Affairs at the same IU School of Dentistry. He is the chairman of the CDCA, and he's a past member and past president of the Indiana State Dental Board. Our next presenter tonight is Dr. Mark Armstrong. Dr. Armstrong is a graduate of Case Western Reserve University, and he is in private practice and has been since 1989. He received the gubernatorial appointment to the Ohio State Dental Board, where he served as vice president in 2007 and 2008, and president in 2009. And our fourth presenter, besides myself, is Dr. Guy Champagne. Dr. Guy Champagne is a board-certified oral and maxillofacial surgeon. He did his undergraduate at the University of Missouri, Kansas City School of Dentistry, and then completed his residency at Washington Hospital Center in DC. He served on the Maryland State Dental Board of Examiners for 10 years and served as the Dental Board's Dental Compliance Officer. He currently serves the CDCA as a senior advisor. So please welcome our hosts. Again, thank you for being here. And we're going to start right out. We do want to keep this to 1 hour. So we want to respect your time. So we'll quickly get into some things and then get to the chat. Please, again, enter questions in the chat as we go. Dr. Armstrong, I'd like to start with you. This is one quite impressive map, but I know that some of our viewers are wondering just exactly what this means. Do you mind go ahead and explaining what we're looking at here?
What you're looking at here from ADEX is basically the de facto national exam. You have all of the purple states which currently accept the ADEX exam. Two other states, both Alaska and Georgia, have both accepted the exam, but are currently do not, won't be effective until for Georgia 1/1 of 21, so January 1st, And Alaska is just in the, the law has already been signed by the governor. It's just awaiting final public review, 30-day review. So that covers every state that accepts a third-party independent exam. New York, of course, is just PGY1, and Delaware also does not accept any third-party exams. They give their own exams. We also show here the states that have the competent exam that are already accepting the competent. 38 states are doing that at least on a temporary basis for COVID, but 18 have already said that competent is going to be the way they are going to continue to accept exams.
So can you repeat that for me, Dr. Armstrong? How long-term, how many was that?
Long-term, 18 states have already approved the competent for licensure, for initial licensure.
And that's for dental? That
is for dental.
Great.
Moving on to dental hygiene, the map is almost just as impressive. Basically a de facto national exam for dental hygiene. California most recently accepting the MCE, the mannequin-based hygiene exam.
The MCE.
Yes.
Yes, lots of acronyms.
All those acronyms, right. But definitely ADEX, the ADEX exam it covers nearly the whole country.
It is quite impressive, and I'd like to direct the state boards. These are interactive maps on our website. So if you go to cdcaexams.org, you will find these maps, and really what you don't get here is the fact that you can hover over each state and see whether it's long-term, short-term, if there's different requirements or things that they've waived, such as perio. All of that is included in these maps on our website. So it takes our team a lot of effort and a lot of work to keep up with this, but please use it as a resource because we're happy to provide it. So next we're gonna move on to Dr. Harvey Weingarten. Dr. Weingarten, I'd love for you to introduce yourself and kind of let us know what we're discussing this evening.
Thank you, Shana. First off, I'd like to thank my colleagues here that are helping us explain this tonight. I'd also like to thank everyone that's taken some time out of your evening this evening to spend, when we get almost 200 people to spend an hour or so with us. We really appreciate you and your interest. So what we're going to talk about tonight, Dr. Champagne is going to talk about the data and the analysis of the 2020 exam. We're going to talk about the evolution of the competent, which is our simulated tooth. It's not an ivorine tooth, it's a special simulated tooth that we introduced this past year, 2021. We want to get feedback from each and every one of you, maybe not all at the same time, but we want to get feedback to see where we need to go. And we'll spend just a few minutes talking about the ADEX OSCE exam for dental and dental hygiene. I do want to forewarn everyone that tonight's discussion is going to be more on the dental side because we have more data associated with that than the dental hygiene side, but we will do one on the hygiene sometime in the future.
Yes, please fret not. We will have a hygiene, we will repeat this with the focus being on hygiene. So please watch your emails for an invitation to participate in that panel as well.
So how did we get here? We got here for one reason, and that reason is that we serve you, the boards of dentistry across the United States. So we're here because in addition to the knowledge that we all have in between our ears, we also need to test the psychomotor skills that allow us to practice dentistry in a way that's going to enhance the treatment of our patients. So one thing you have to understand and know that 4 years ago, my predecessor and mentor, Dr. David Perkins, stood at the dais at the national meeting and said that he believes that the day of the patient-based exam is going to go away. And to that point, he appointed a task force and began the process of development of what we now know as a competent tooth. And that is something that's important because this was not a response to COVID-19. It's certainly filled the niche for COVID-19, but this has been in the development stage for a long, long time. So what we did a mode effect study in 2019. We did a pilot program in Mississippi, and in order to make sure we had enough data, we went to 6 schools from across the country did the maxillary mandibular trials, compared them with some natural teeth, and you'll hear about those results pretty soon. The cohort study became the 2020 examination because of COVID-19. We then took our results and turned them over to the specialists, ACS Ventures, the psychometricians, so they could psychometrically evaluate this past spring, and they published a paper associated with that. So we had everything ready, and prematurely, when I say prematurely, we weren't expecting that it would be utilized so much this year, but we went to ADEX, and in April of 2020, they had a special meeting, and they approved it for utilization for the pathway to licensure. So it's a long way of saying that we've had almost 2,500 teeth prepped, evaluated, certified, either appropriate or short of the mark by the examiners. So that's how we got here. As part of that process in getting here, we utilized the services of many of the specialists, if you will, in restorative dentistry. We had the advantage of having Dr. Mark Brennan from Maryland, Dr. Peter Yeaman from Michigan help us develop this along the way. We had the practicing dentist, Dr. Mark Armstrong, did the same, as well as our in-house specialist, Dr. Ellis Hall, Dr. Stuart Blumenthal, who helped develop the different aspects of the tooth that brought us to where we are today.
That's quite impressive, Harvey, and not only that, but how quickly these exams were administered in a time of need for the candidates and the state boards looking for a way to get through this.
Well, it was a game changer, without a doubt. And we were very fortunate that we were out in front of this curve. And not only we were out in front of the curve for the examining bodies, but we were very fortunate that we had the participation of the schools, because the schools allowed us to come in where we had almost 700 students take the exam, that we could glean the data that helped us justify to the boards of dentistries that it was appropriate.
Dr. Armstrong, do you mind if I turn to you real quick and ask you, can you let us know, or you're part of the development team. How did that go? What was your experience, not only with the development, you've also administered this exam yourself as the chief of the exam in multiple locations. Can you just give us some quick feedback on both of those two topics?
Yes, the subject matter experts, Dr. Yeaman, Dr. Brennan, myself, Dr. Hall, Blumenthal, we all worked with this tooth through the initial development, fine-tuned it through each step of the way. When we found issues with such as brittleness of the enamel or difficult problems with fracture or things like that, we got to work with our manufacturing partners at Accidental, and each step that we found that needed to be improved, they could improve it. So having clinical experience with the way the teeth, way natural teeth act, and how the mannequin teeth should react, the competent, was very helpful. And having that input along the way and having a very responsive accidental team has really helped develop an excellent representation of a human simulation.
And how about your exam administration experience?
It's amazing.
Let's take it to the chief role.
Yeah, it's truly amazing though, watching the way the students come in and approach the exam. I mean, with a patient-based exam, there's the anxiety of, okay, my patient's not going to be there, what's going to happen, how is it going to happen? Everything is completely toned down from an exam perspective. I mean, it's just a very quiet serenity almost. You just don't have the nervousness from the students, and I think they truly perform better. I mean, they don't have the stress. And yes, one of the things is, oh yeah, well, you don't have a patient to deal with, you don't have saliva, things like that, but we are still testing the important psychomotor skills of the restorative portion of it with this competent tooth.
And I know you've had some direct feedback from the school. Any of that you care to share?
Yes, we've had the opportunity to let the clinic administrators and deans look at the test as we're administering it. And every one of them that has looked at it, basically their eyes just go goggle-eyed. They're like, I can't believe this is really a mannequin tooth or an artificial tooth. And it's certainly not like the ivorine teeth that are out there and some other exam organizations are using. They say this is a human simulation, which is excellent to hear from the actual faculty and deans.
And we'll get into that. I'm glad you mentioned that, but we will get into the real differences of this tooth of the Confidant versus what else is on the market. So Dr. Weingarten, I'd like to come to you because you're in a little different position. You're actually at the school with the students, serving them through this process. Tell me how, from IU's perspective and your own personal perspective, how that's been.
Well, as Dr. Armstrong has mentioned, it is a game changer. And for those educators that are in the audience tonight can attest to it, that a lot of time, effort, money was spent in preparation of getting ready for the ADEX exam, or any exam for that matter. What happens now is that's all eliminated, so you can focus on teaching your students. It's almost a 180-degree turn. Where it used to be the students were practicing on artificial ivory and teeth almost every night in preparation of the patient. Now they're practicing during the day in the clinics on their patients in preparation for the simulated tooth. And so it is a game changer as far as the educational process is concerned. It replicates the natural tooth as close as anything that anyone has ever seen.
Yeah. And we've heard that time and time again. We do have some feedback we'll share along the way. And if you have some feedback, please, feel free to put that in the chat. I am going to go ahead and go to our chat, as a matter of fact. And Dr. Larson, we will cover this, but Mark, Dr. Armstrong, Mark has asked, any negatives in using the Confidant?
Yeah, primary negative that we saw with the performance of the Confidant was early on with enamel chipping. And as we have, as Accidental has, as we've gone through that, that has really almost been completely resolved. We see that very infrequently anymore.
Perfect. And we will address just a few of those things, some other things as well. The improvements, the enhancements that have been made on this tooth to really step up and differentiate the first generation, as we're calling it now, from the second generation that's coming. So with that, I'd like to turn over to Dr. Champagne. Dr. Champagne, how are you this evening?
I'm doing well, thanks.
Good. Well, I'd like to turn it over to you now to kind of give us, what our state boards are here to hear is really about how this is different from a patient-based exam, or how it's not different from a patient-based exam, is really what you're getting ready to tell us about in our criteria, content, and scoring.
Okay, are we going back to the slides?
Yeah. Yep.
Very good. Okay, actually, I'm going to digress for just a minute before I start getting into the meat of the statistics here, and really address why are we even talking about this? Why is it so important? Because many of you know, because I've talked to over 20 dental boards since COVID came out, you're being asked to accept a computer exam without any performance exam. You're being asked, in spite of the fact that clinical experience and training was abbreviated by 2 to 4 months, that we don't need that we can test everything on a computer. Now, I got to tell you, ADEX has always understood the importance of anoscopy in dentistry and dental hygiene. It's the longest continuously maintained OSCE in dentistry and dental hygiene in the world. We understand the need for it. But when I spent my 10 years on the dental board, I tried to not put myself in the position of the dentist, but of the patient. Imagine if it was my son or my niece or my parents, the treatment that they got, what would I demand? They're asking you to believe, and let's put it on a lighter plane, that if you're in a golf tournament and I take an exam and I know how to hold the club, address the ball, stand, how to read the green, I can pass a written test. But nobody ever saw me play golf. You want me as your partner. I can assume they play. Well, the patients have a lot more at stake than that game. So if it's my son and he's at college and he has a small lesion, ends up with a root canal, that's meaningful. I don't care what they did on a computer exam. I don't care what they did on another patient. This term, single encounter exam, as if it's negative, it is emotionally charged, but the patient calls that their treatment. So that's why we're addressing this. So when we came up with this simulation, we did not want to write a passage. We did not want a D1 or D2 exercise We wanted to simulate all of the important components of a patient-based exam. So this first slide that I'm showing you now, if you look at the right side, that page doesn't exist. It's just there to show you that unlike other exams, the ADEX exam doesn't have a special manual for our confidant exam. Every criteria, every evaluation point that's used in the anterior and the posterior restorations are included in our evaluation. In fact, the exam is conducted in the same way. So there's clinic floor examiners that do not get involved with scoring, do not get involved with modification requests, but assess that the patient's in an anatomical position, the shroud is in place, they are treating this typodont tooth and the patient as if it were a patient. It goes back to a separate grading area of anonymous graders who grade on site in real time, evaluate modifications, evaluate the preparation, evaluate the restoration on that preparation. That page on the right doesn't exist because we changed nothing. We wanted to be able to evaluate everything that we do on a patient-based exam. Next slide. So the confidant tooth, as you heard both Mark and Harvey allude to, is not a typodont tooth. Anything you think about a typodont tooth doesn't apply. This is a human tooth simulation. We evaluated every potential tooth on the market. We didn't want to reinvent the wheel if there was something that we could utilize. In fact, we've continued to do that. So we've just gone through, just this last month, reevaluating every available tooth on the market other than ours. As you know, it is it is patent pending. What is the difference? First of all, what we found is other teeth on the market and still the other teeth on the market, the caries is discrete and uniform. Every time you enter that tooth, if it's a 8 mesial, it's the same exact 8 mesial. That doesn't happen in a human tooth. Caries is variability. It transitions from infected to affected dentin to decalcified dentin to sclerotic dentin. We need to know that you have the diagnostic skills to know what's diseased tissue, what's normal tissue, when to stop. Every tooth is variable. You saw Harvey present the statistic of over 1,200 candidates. All 1,200 of those lesions were all different, just like in human beings. It had a different amount of stained or unstained caries, different amount of promulgation along the DEJ, different amount of sclerotic dentin. So we can test what we're supposed to test, variability that you see clinically in real time. The enamel, the DEJ is lifelike, is not like the others. There is a discrete interface, just like there is in a regular tooth. You have to bond to the tooth to keep the restoration in. In fact, we can evaluate every component of the exam that we have. So how did it perform? Well, that's the amazing thing. So we now have a cohort, unlike the last time we presented, we have the same cohort that took the patient-based exam and the confidant exam. And if you look at the statistics, they are essentially identical. Now that statistic in and of itself, as you see there, is actually meaningless if you didn't see the slide 2 slides before. What makes it meaningful is the exam is administered with the exact same process, the exact same grading, and the exact same evaluations. If it isn't, anyone with a background in research would know you can't compare the results. So what is important, if you dig down into this, they're failing for the same reasons. They're failing because they have remaining decay they did not recognize, or that they asked to remove decay that wasn't decay, or they had an unrecognized exposure, or debonded restoration, or marginal defect, or adjacent tooth structure damage. Everything we see in a regular tooth, that's why these statistics are so significant. They're failing for the same reasons. And what's more important, we look at the effect of modifications. And if you look at both the patient-based exam and the confidant exam, the thing most closely associated to failure is modification requests that are denied. So if you don't have that process, you can't evaluate judgment. Next slide.
So while we're switching to the next slide, I'm going to ask you a question, Dr. Champagne, that was just submitted. If the tooth performs as a natural anatomical tooth with the variations of the amount of decay, why continue to have prep parameters?
Well, that's a great question. So that's in fact essential today, isn't it? So when we're doing composites, unlike amalgams in the past, we're making conservative preparations that we treat the disease. This is unlike a patient base because you cannot select a lesion that's so small you won't need modifications. You will, and this evaluates our ability to evaluate your alteration in preparation based on the disease that is or is not there. We don't have fixed values other than over preparation beyond the disease without justification. So everyone would agree that over preparation without justification is potential damage to the tooth. We agree with those principles of preparation. We can test it. That's what the variability is there for.
So I think that's important to repeat one more time about the modification request and the way that they manage the prep.
So the fascinating thing in the deep dive we've done statistically analyzing this versus a patient base is if we can train technicians. So if I give a D1 or D2 exercise, cut the ideal prep and feel the ideal restoration, I don't know what they're going to do with actual disease. I don't know if when they see a patient that doesn't conform to the ideal, what's going to do. That's what we train for. We train to treat variability. Modifications is the process we use where a candidate says, hey, I have to go beyond this parameter, either the internal or external preparation because of the disease I see, and here's why and here's how much. Here's my diagnosis and here's my alteration in the treatment plan. We can evaluate that with modifications. They have to do that in this process because of the extent of the caries. We can affirmatively tell every dental board, we tested their ability not only to detect decay, but detect the absence of decay, not by stain, not by color, but by tug back and the actual diagnostic parameters that we use on a patient.
Shane, another reason is these students are very smart. They wouldn't be in dental school if they weren't bright. And they talk to each other all over the country. And if you don't have variability, they will game the system. They'll say you cut in 3 millimeters deep, 4 millimeters high, half millimeter this way, whatever, and they'll turn it in. And so you need that variability so that they can't game the system because they will speak to each other.
This is true.
And to that end, Harvey, and you're so right, it's the fact that when we look at the performance of these 1,200 candidates, and in this first year, they all did 8 mesial, for example, in the anterior, performance did not improve because every tooth was different. Every tooth had a slightly different extent of decay, mix of decalcified enamel and frank caries, sclerotic dentin and frank caries, or a stained or unstained dentin. It did not improve their performance. You can't game it just like you can't game it on a real patient, and you can't practice for it because even if they had practice teeth, which weren't available, every tooth is different. Doesn't help you. So you have to be able to apply the principles of patient treatment with this, with the Competent tooth. And there's no other tooth like that. So that's the important thing. And when we get to the next slide, I'll explain that. And, you know, we're scientists. Our obligation is to critically evaluate everything we hear. And that's your responsibility on the dental board also. Even what comes to us, we have to prove it to you. And the next slides are because in speaking to the dental boards, as I've done so often over the last 3 or 4 months, we keep getting compared to other exams as if it's the same tooth and the same process. And nothing is further from the truth. This wasn't developed for COVID-19. We didn't have to rapidly deploy. We wanted a simulation. We started developing this, as Harvey said, in 2017. So we were just lucky. It was fortunate. We finished the evaluation in time to implement it. We're not the same as other exams. We've evaluated the teeth. They do not have the variability. They don't have the same tug back. They don't have a discrete DEJ as we do. And the exams aren't done the same. So this is another exam that's given where 3 restorations you do it on pre-prepared teeth. Well, the problem is that those are ideal preparations. That's not the variability we have here. Plus, with our teeth, you have to bond. You have to be able to restore the anatomy on something that is not uniform. Every preparation is different, just like the patients in your office. It's not a uniform exercise that you can train for and gain. And if you look at the other major exam, which is on the next slide, they even go so far in their literature to say that this isn't a permanent exam. It was only meant for COVID, but that's the tooth that's filled. I mean, if that's a challenge, if that's the threshold for being able to practice, to fill an Ivorine ideal preparation with a restorative material, something's wrong, in my opinion. We did not want to give a rite of passage. There's no reason to take an exam if we aren't really examining. And it doesn't matter what the pass-fail statistics are if they are not done in the exact same process, evaluated with the exact same criteria, and fail for the same reasons. Otherwise, that pass-fail outcome is for a different reason. It's not based on the criteria we would evaluate a patient on.
Well, and I think that's quite impressive, and it speaks to the work that's been put into this exam for the 3-4 years that it was in development. And this picture says a lot. The picture's worth 1,000 words, as they say. Dr. Weingarten, can you tell us a little bit about, Dr. Champagne's presented on some things. Can you tell us what you see here and what we're demonstrating?
Well, we're demonstrating a couple of different things. Number one, you'll notice that we're not wasting PPE. The candidate and the evaluator are wearing a mask because they want to be safe. But you notice that the examiner does not have on gloves because we don't have to worry about cross-contamination. That's one thing. Number two, last I checked, each one of our patients has shown up, because as long as the Foot Locker shows up a week ahead of time to the school, every patient is in that Foot Locker. Number three, there's the variability, and it is evaluated the same way it is prepped. It's not evaluated on a bench top, opened up. It's evaluated, looked at, just like you would look in a patient's mouth. You'll notice they both have on magnification. So what's represented here in reality is the two exams are identical, and identical to the extent that there are no differences. The biggest difference is the tongue and the saliva, but we're working on both of those, trying to figure that out. But maybe someday we will. But it is identical to the patient-based exam.
Now, Dr. Weingarten, you mentioned one of the favorite parts of this exam from the candidate's perspective is their patient shows up. We did have a question that somebody has submitted about previously did candidates fail due to patients not showing up?
Well, not if they took the ADEX exam. If the patient didn't show up and they did not challenge the exam, then they were allowed to retake the exam. Sometimes the following day, if we were there for 2 days, generally speaking, the next time we came back to town, they would have to travel. There is no failure if you don't challenge a part of the exam.
Now, in this, the additional question to that was, well, what if they had misdiagnosed caries? At that point, they've submitted a patient for this exam. So that's different than the patient not showing up for the exam.
You are correct. And we're going to talk about, as we get to the next slide, we're going to talk about some of the changes that we're making in the exam and what the future is going to hold. The first thing that's going to be different is the available teeth with lesions. We are working through a process where we're going to have 7, 8, 9, and 10, the 4 anteriors, 19, 20, 29, and 30 for the posteriors, all have lesions in them, both mesial and distal. The student or candidate will be given a radiograph, and they will have to diagnose which one of these teeth is appropriate to restore for the exam. So again, it is going to be further challenging them and their abilities for the radiograph. We're going to have an enhancement to anatomical structure. When I say that, the enamel sometimes was too ripply, sometimes was too smooth, and they've been working to enhance that. and to make sure that with respect to the adjacent teeth, that all the teeth look the same. So, you know, one of the issues on occasion is someone will prep the wrong tooth. Well, it's easy to, when you look, you see one tooth is different than the rest of the mouth, but this way you'll have to be able to read a radiograph, know which surface and which tooth to work on.
Harvey, one of the questions in the chat so that people don't have a misconception, the variability in caries that we've been discussing has been there from the beginning. That's what makes the Compodon tooth, one of the main things that makes the Compodon tooth, that it simulates human caries. That variability has always been there. So everyone who's taken an exam, although they took the same lesion, i.e. same surface, it wasn't the same lesion, that variability was there.
Correct. And now as we move forward, we're gonna have more options, because there'll be, instead of everybody doing the mesial of 8, some will do the distal of 8, some will do the mesial of 7, some will do the mesial of 10, distal of 9, mesial of 9. But the variability, the mesial of 8 on all the teeth will not all be the same. You'll still have the variability that we had on the original tooth.
So I've got a question here about, you know, the enhancements that we are making. Are one of those enhancements involving pulpal exposures? Will that become, you know, how is that handled now? Will that be an enhanced feature in the future?
I'll let Dr. Armstrong speak to that.
Yes, actually, there was a pulp chamber, and we did have candidates fail because of unrecognized pulp exposure. But at this point, for this first round, you didn't see the red, and of course, it didn't splurt out at you or anything like that. But the enhancements will be similar to what we do with our endopros exam, where the pulp is actually red and there is actually material in it. So it'll be a recognized exposure.
When will the 2021 phase 2, whatever we want to call it, when will that be? That'll be in effect for this 2021 class starting January?
Yes, starting January 2021.
Okay. And just to repeat one more time in case it wasn't heard, the enamel hardness of the adjacent teeth is also being addressed, correct?
Yes, those teeth are going to be exactly like, they're going to be set up Compodon teeth next to each other, so that, yes, that is one thing that in the initial study, they were not.
And one last question, rubber dams. Are rubber dam use on the Compodon?
Well, as in the patient-based exam, a rubber dam must be placed when the tooth is sent in for evaluation. They do not have to use a rubber dam for their preparation or restoration, but that's not different than in a patient-based exam. But when they send it in for evaluation of the prep or for modification request, a rubber dam must be utilized. And just stepping back, we know we have the enamel right because of our evaluators. Half of them thought it was too hard and half of them thought it was too soft. So when you get 4 people that don't agree on the same thing for the right reasons, you know you have the enamel at the right hardness.
And another question, Dr. Champagne, the purpose of increasing tooth selection, do we believe it'll affect the pass-fail rate?
No, actually the reason we want to increase the number of lesions present is 2 things. You ensure to a greater degree you can't game it. In other words, you don't know what lesion you're going to do, but it also simulates with greater fidelity how you treat a patient in your office. So we're not going to assign them a tooth. We're going to give them a radiograph, say diagnose the lesion and treat it. The radiograph will only show 1 lesion. It won't show all the lesions. So it will have 1 lesion. They will have to make that diagnosis just like you do in your office and then treat the appropriate tooth. So it's to increase fidelity to practice. Again, human simulation, not a mannequin exam, not like the endo and the pros exam. This is totally different. This is where we test patient principles.
I like that, human simulation. I like that a lot. All right, so we do want to leave time for questions. We've got a few more slides to cover. We'd like to talk about hygiene. It is important. Its development of a mannequin-based exam has been requested by state boards. We have delivered on that product. We have delivered more mannequin exams than any other testing agency. So with that, I'd like to go back to our presentation and talk about Dr. Weingarten, Dr. Armstrong, can we talk about the hygiene exam, give it a quick overview, but also kind of tease the information that we'll be presenting in our dental hygiene webinar coming up before too long.
Sure. What we want to do is remind everyone that just as we started in 2017 on the development of our Confidant tooth, the ADEX CSCE OSCE exam began in 1979 as far as delivering to the hygiene practitioners. So it's not as if we just came out of the woodwork and developed this exam. This exam has been around for over 40 years. The 30 states that accept the dental hygiene exam at this time, and this season alone, we have delivered almost 1,500 exams, of which 1,108 were mannequin, non-patient based, and just about 300 were patient based. The biggest reason for that is, as everyone knows, the dental testing season begins right after the first of the year, and so we had a significant number of exams before the COVID shutdown, where the hygiene season begins usually sometime in April to May, and by then, most of the schools are not allowing patient-based exams, so that's why there's the discrepancy with so many more mannequins. We also have to recognize that the mannequin exam, even though we believe it has much potential, is not 3.5 years into development as a Confidant tooth. So we recognize we have additional work to do on that, and we're in the process of working with our manufacturing partner, Accidental, to get that taken care of. And you'll find that there are some states that will accept the OSCE alone for dental hygiene licensure. And I would defer to Shana, she's the expert on knowing what states will accept what. And you know, the enhancements we have are totally in development, and so just stay tuned.
And I will say, from my experience from hygiene, it has kept us extremely busy. We're grateful to be able to support the schools and the state boards in the fashion of a mannequin-based exam in conjunction with our written OSCE. I think that I really want to emphasize the importance of the dental hygiene exam, the psychomotor skills on the mannequin base, but in conjunction with the OSCE exam, 115 questions these candidates also take to complete the ADEX process. So they are still meeting the occupational analysis by doing both components. We have kept both components, we've maintained them both. It does make this exam strong because of both. So I do want those of our dental hygiene and state board members out there listening that this exam with both the mannequin base and the OSCE are imperative to do together. I'll quickly comment, you mentioned the 3 states, Dr. Weingarten, the 3 states that accepted the OSCE were Oregon, Texas, and Kansas. So the students in those states, or they were graduates at this point, were very happy to take the OSCE. We served those states just as well as we've served any of the others in being able to be there when they needed us. And again, we kind of talked earlier, the reason we don't have any preliminary results tonight is because we've been delivering this exam since April, and well, actually since June was the first hygiene exam on a mannequin. So we do need time to develop that and give you accurate numbers in order to really present that. And that will be what our focus is on our next webinar call that strictly focuses on hygiene, so that we can not only give you statistics, but also give you the enhancements that will be coming for the next following season. Anything else, Dr. Armstrong, you want to add about hygiene?
No, thank you. Just stay tuned.
Perfect, perfect. Well, it's been exciting. Some of you may know we've been called upon and presented the hygiene exam to schools that are new to us, to the CDCA, and it's been exceptional experience for both parties, both us, them, and the students to have this opportunity. So for those state boards who look to try to assist, we appreciate that, and I know the candidates do as well. So to kind of circle up, we've got about 10 minutes left. We do like to show the map one more time and also give you some quick feedback of just what we've heard. I know we've talked about it, but Dr. Armstrong, I'm gonna come back to you real quick. Can you just give us kind of a synopsis of these things? My favorite quote actually is in the second statement here from the candidate. These are from candidates who took the Confidant exam. If you don't mind giving us a quick review.
Yes, comments from the students have been amazing. I mean, they say it's very lifelike. It certainly does simulate. They feel what they would expect to feel in a patient, and that's something that, like you said, and like Dr. Champagne referred to, really in the other system, you game the system and pick the smallest lesion possible and just put the burr to it, and decay is gone before you even feel it. And that cannot be done with the Confidant. You are actually being tested on your knowledge and your psychomotor skills. So yeah, having the students say yeah, that feels like real tooth is very, very good feeling.
And my favorite though is the part where he or she says that it was larger than they would normally bring on a live patient exam. That is exactly why we've done what we've done. It makes it, when I read that the first time, it made me chuckle. I thought, he's got it, or she's got it.
Yep.
And then our next slide is just some feedback. Dr. Weingarten, I'm gonna ask you to kind of give us and wrap this up as far as feedback from examiners and schools and a long time licensed practicing orthodontist there at the end.
I refer to this slide as the Grand Slam. It's the Grand Slam because all the partners involved. The first one is a school. Dr. Fischbach from Ohio State University talks about in his newsletter the advantages to the exam. The second one is a longtime examiner, Dr. Mel Kirshner, talks about how it equivocates and there's less issues associated with the Confidant tooth as the patient exam. And the last one is someone that is actually a candidate that hadn't picked up a handpiece for years and years and years, but then decided that wanted to switch states, and in order to go to Florida, he had to go through the exam all over again 46 years later. So I think if we add those three together, it shows for the state that this is truly a grand slam for everyone involved, for the schools, for the students, for the candidates, for the examiners, and for all of us together allow us to test what we have been teaching our students for these past 4 years, and so they can show that they deserve the opportunity to join the profession in our states.
So we're going to come back here. Again, the PowerPoint's nice, but it's also nice to have just a few minutes to chat with you all before we log off. One of the questions that we had planned to address was about perio, and we do have several questions about perio. And are we doing any research and development on a periodontal examination on a mannequin? And is there any data available on the periodontal mannequin exam? Dr. Champagne, I'll let you take that question.
Well, first I want to say ADEX has the most extensive periodontal exam in the country. On our OSCE, we thoroughly evaluate diagnosis, treatment planning, prognosis, implications for other dental treatment in not only complex patient-based scenarios where you have to call for the records, but with alternative item types, extended match, elicited response. We extensively test perio. I'm assuming it is about scaling, not the periodontal test. We test periodontics. Understand that, quite frankly, in this area, all the testing agencies are in agreement. Periodontal scaling does not make the cut score in the occupational analysis. It is not required in the other two exams that you saw earlier, as well as the ADEX exam. But as far as a mannequin-based scaling exercise, that's in development. Obviously, it would be a similar typodont, if not the same as in the dental hygiene exam. We are improving that. None of the products that are out right now, quite frankly, meet the standards of a human simulation like the Confidant, but we plan to change that. It will be exclusive to ADEX. So that will be on the horizon. We I think, Shana, we're going to begin to offer the mannequin perio-scaling exam starting September. Is that right? Or not?
It will, we are administering it in a few schools who needed it. It will be fully available to candidates for the 2021 class. So in January, we will be available. It is available now, but we're doing it at places where we've been requested to administer it.
And quite a few states, and I think it's important, as a result of COVID, have revisited their requirements and have dropped the perio-scaling requirements. And quite frankly, some states realized they couldn't have required it all along because they didn't have the statutory authority. It said pass the ADEX exam and the required parts. Perio-scaling has not been a required part for the last 10 years with ADEX, as it is no longer a required part in the other licensure exam. So I think it is, the number of states requiring it is decreasing, and COVID took forced states to look at a fresh look at it. But for those states that require it, of course, we will serve our member state boards.
And just to reiterate, because I think what you said is really important, is the difference of the perio scaling versus what we are testing perio on the OSCE. Those two things are still being tested through the ADEX exam.
We have not dropped testing in periodontics. You cannot pass the ADEX OSCE if you don't pass the periodontics section. It's weighted too heavy. It permeates the entire exam. So periodontal diagnosis and prognosis and evaluation really impacts 80% of the questions on the exam. You have to take that into account. More importantly, you have to ask for the records. It's not offered. You have to ask to see the charting, ask to see the x-rays, ask to see the information you need. You can't ask for it all the time. You have to ask for the relevant information. You're going to run out of time. So we very thoroughly tested. It has been refined really consistently over the last 12 years. You can feel comfortable. We thoroughly test everything a dentist actually does in periodontics.
Well,
and it's required.
Dr. Armstrong, Dr. Weingarten, anything else you'd like to add from a different perspective?
No, thank you.
Nothing to add at this point. I just wanted to thank my colleagues, my co-participants, as well as those that took the time out of their evening this evening to join us, and to let you know that here at the CDCA, we always welcome questions, comments, thoughts. Feel free to get a hold of the home office or get a hold of myself as chair, Mark as vice chair, Shana as our school liaison representative at any time whatsoever.
Well, yeah, I still have 5 minutes with you. I can't let you go yet. I have some other questions.
Okay, well.
Well, we were fortunate enough to have some pre-submitted questions. So with these pre-submitted questions, I'd like to just kind of quickly run over those with you all and get some responses. One of those was about the scanning technology in the future for grading. Where are we with that? Is that an option? Dr. Champagne, I'll ask you to address that for me.
Really, this is a question for test development. For example, one of the principles are fidelity. We have to follow what dentists do in their office, and it has to be a majority of entry-level practitioners, a critical mass. When a critical mass of entry-level practitioners use a scanner to evaluate their own preps in their office, that allows us to bring that technology in for grading. We can't do it until that's what dentists do. We can't utilize a technology that dentists don't utilize in their first 5 years of practice. And I mean the majority of practitioners. When and if we offer that, when that comes about, it will also be incumbent on our testing centers, the schools, to have that same scanning technology for the candidates to use during the exam. So we want fairness is a very important principle, and fidelity is another important principle. We have to do what dentists actually do.
And another question that was submitted, Dr. Weingarten, I'm going to present this one to you. You know, mannequin, I'm going to take dental, mannequin versus patient testing. How do we know a newly licensed dentist can manage people?
That's a great question. And if you look around, if I look at my 120 graduating students from last year's class and 116 are in this year's class, there are 116 distinct different personalities. Some can manage, some will never be able to manage. That doesn't mean that they're going to become bad dentists. It just means they'll become oral surgeons. Just seeing if guy was listening. Point being is we are testing their professional competency, and unfortunately, none of us are trained in the management of ourselves, of others, and we have no control over that. So we can only test what we can control. But that's a great question. I just don't have a good answer for it.
We can test now the clinical management of patients. That's what the simulation is about. I think you have to look at this as like advanced cardiac life support. That simulation test is superior to any patient-based test on the cardiac life support because you can increase variability. Some things don't lend themselves to standardized testing. We don't test their ability to manage a patient right now. One patient doesn't test their ability to manage a patient. They self-select that patient. It's usually a very cooperative, friendly patient, often a family member. Some things have to be done in a longitudinal basis. That's why clinical experience in the dental school is so important. That's why this is so important, because that abbreviated clinical experience is probably going to continue in the future because of the restrictions COVID-19 is putting on dental education, not just in the past year, but going forward.
And, you know, Ellen Legg has submitted a question. I'm going to answer her question. She's asking about exams. You know, there are mannequin exams, and this is for hygiene, but the same could apply for dental as well, that are being given. But are there any openings at these sites for students who haven't had an exam yet? And really what that is we've been restricted by the schools having the ability to host outside candidates. They just really haven't had that ability. So what we've done is, you know, the schools who are willing to be open have done more than their part this year to help out and definitely raise their hands and allow outside candidates. In response, I'll give you an example. In Nevada, we just had a situation where the students were able to take the mannequin exam. We had an exam coming up that was a dental exam. We've added a hygiene exam so that students have the ability to access an exam. The thing is, we need to know about it. If we aren't getting the communication, if we aren't knowing what's going on, that, you know, and schools aren't volunteering that information, then we can't assist. But if you let us know, hey, there's a need and this school is willing to fill it, then we absolutely will do our part to host an exam to meet the needs of the candidates who need us. And then last but not least, we're going to end. We've got 1 minute left. What is the expectation survival of, and I'm going to read it as it was submitted, of the human subject exams? Dr. Armstrong, do you mind taking that question?
Well, I'm sure there will continue to be states that feel the best test for a candidate is how they manage a patient. But there are so many states, not even just given the circumstances of COVID, but given their own circumstances, that have decided we really want a non-patient based exam. So the CDCA is there to serve them for that.
Guy, anything you'd like to add? Any final say-offs on that?
Yes, I would reframe the question. We don't use human subjects. It's not experimental class 2 or class 3. I mean, I'm not a restorative dentist, as Harvey pointed out. I'm the person who can't do it. But we don't use human subjects. It's evaluation of patient care. I think in the long run, I think it's going to decrease in popularity across the board, especially as simulations can improve the exam. If we can test something, we can test more with a simulation. I think that eventually states will become comfortable with not having patient care as part of the process and the downside of that. But I think it's going to be an evolutionary rather than a revolutionary process.
Well, I'm going to have our chairman sign off for us, but I would first like to thank you all for coming tonight and being a part of this. We really appreciate it. We also want you to know that we are available to meet at your state boards. This was truly just to get this information to you all. We still want to be very much involved at your personal state board meetings, so please feel free to reach out to myself, CDCA, Stephanie Beeler, some of you have had contact with her as well. Please reach out to us, let us know how we can meet those needs at the state board level to answer any further questions. And with that, Dr. Weingarten, I'll let you sign us off for tonight.
All right, well, first off, I want to thank everyone, in particular, someone you've not seen their picture is Stephanie Beeler. She's the behind the scenes person that has really put this together along with Shayna. The true heroes in our organization are those that work in the home office, assisted by Alex Vandiver, our CEO, and his entire staff. They make this happen because they do it for each and one of the candidates so that we can provide what the states need us to do. So we work for you. We're happy to do this for you. We love doing this. We're all practicing practitioners, semi-retired practitioners, and we don't do it for any other reason that we want to make sure that we're meeting the needs of the states. So if you have a need, let us know and we'll try to fulfill that need. Thank you.
Dr. Armstrong, good night. Dr. Champagne, good night. And to all of you, thank you so much for coming. And again, thank the team at the CDCA. Have a great evening.